for many years, in fact, decades now, I've been working on anti-amyloid immunotherapy in the non-clinical world, so testing it in mice mostly, and looking also in some tissue culture assays, but trying to, uh, first of all, get it to where it is now, to the clinic, which is important. I started working on this in 1997. And then as we became aware of this vascular side effect known as amyloid-related imaging abnormalities, or ARIA, I became very interested in that because while I was very pleased that anti-amyloid immunotherapy was moving forward, this is a serious, it can be a serious side effect in about 1 to 1.5% of patients. In the rest of the patients, it tends to be asymptomatic. So there's two forms. ARIA-E is edema or effusion, and that tends to occur within the first 2 to 4 immunizations, typically, or doses. And ARIA-H, which is hemorrhage or microhemorrhages, and that tends to occur a bit later. It's not something that typically is seen very early on in the clinic. And so my lab became very interested in trying to understand what is causing this vascular side effect. Now, at the same time, my lab has been studying complement since I think our first publication was the year 2000. So we've been very interested in complement, mostly looking at how it relates to synapse loss in the aging brain and in Alzheimer's disease. But in educating ourselves about complement, we knew that the classical complement cascade has a very strong function in removing immune complexes. And by immune complexes, I mean when an antibody binds to its antigen or to the protein. So let's say an anti-amyloid antibody binding to beta amyloid in the brain, that activates a whole immune response, which then complement C1q should come in and bind to its receptor on the, to its binding site, not receptor, to its binding site on the antibody. So all of the antibodies, IgGs, have this portion of the antibody that can bind to C1q. And the purpose of that is so that it can activate the classical complement cascade that will then help remove or phagocytose that immune complex and get rid of it. And this works in many other systems. So if somebody gets a virus or a pathogen, the same thing happens. An antibody comes in, binds to that, and then complement C1q comes, tags it, and then you start this whole classical complement cascade. So we were very, very interested to see if maybe that same process is happening in the brains of mice and people being immunized with anti-amyloid antibodies. And in our mice, we've now seen, and what I present at this meeting is that very, very early on, keep in mind, ARIA-E happens very early in humans. So we had seen that, if you immunize a mouse for 13, 15, 16 weeks in a row, you can actually detect microhemorrhages. If you use this antibody, that's the murine version of bapineuzumab. And bapineuzumab was actually, it's not in the clinic now, but it was the first antibody to go into human clinical trials targeting beta amyloid, and it induced ARIA. That was sort of the definition of ARIA came about because of bapineuzumab. So the murine antibody, the precursor to bapineuzumab, is very reliable. It can always always induces microhemorrhages in old mice if they have CAA, if they have vascular amyloid. So we started looking at that, and we knew that if you look at mice that have been immunized 15 or 16 times, that we would see complement along the blood vessels. We would see binding of the antibody to the blood vessels and to plaques in the brain. But what became interesting then was what happens if you look at the very beginning stages after immunization, because in humans it's happening early. So we started looking at very early stages. And so we immunized mice from on day 1 and day 4, and then euthanized the mice on day 7 And what we saw was that the antibodies were only binding vascular amyloid. They didn't get into the parenchyma and bind plaques. And where they bound to vascular amyloid, we saw this big increase in complement C1q binding. So we can actually see, and I show in my talk, co-localization of the antibody with CAA with C1q in the brain. So to me, that's pretty strong evidence that, that complement is getting activated very early on. And complement has all these downstream effector functions, including phagocytosis of the immune complex, but other components of the complement cascade can recruit immune cells to the area. So we're starting to look at that now, which immune cells are being recruited to these areas. We're doing RNA sequencing. So as part of this talk, after 7 immunizations, we looked with bulk RNA-seq, and we did see very strong upregulation of innate immune genes, including complement and macrophage genes and astrocytic genes. So there's definitely a local immune response going on, at least pathologically, and then in terms of the brain itself, there's this big upregulation in complement and other innate immune genes. And then we looked at blood in these mice and the brain and looked for complement there. And in mice that have been immunized, I don't know, maybe I think 13 times, and they get immunized once a week. And so those mice, when we looked in the brains, we saw that there was no difference in C1q levels between the 3D6 immunized mice and the control antibody mice. But when we looked at complement C3, which is further down the cascade, we saw that there was an increase, huge increase in C3 in the brain. And in the blood, there's actually a very significant reduction in C3. And again, no change in C1q in the blood. So when we looked at C3 in the brain and then looked at microhemorrhages, there's a really striking correlation between the C3 level in the brain and the amount of microhemorrhage. So we're very, very interested in this relationship now. And we think that there's probably a temporal pattern to ARIA, that early on, it might be getting activated by C1q binding to the antibody and CAA. And then as that sort of resolves and you start getting more and more leakage around the blood-brain barrier, you get more antibodies going into the tissue, into the parenchyma, and binding plaques. And so there's sort of this sort of temporal pattern, and that as time goes on, again, you get more and more of this complement C3 upregulation, which seems to be more involved in the downstream microhemorrhage effect.